Thanks, Becky, and good evening, everyone. As Becky mentioned, my name's Tom Kallis, and very much I started off life in community pharmacy, and then later moved into working in general practice before going into a research role. So tonight, what Becky's asked me to talk about essentially is how we record notes in the scope of clinical services, both for community pharmacy and for other primary care settings also. So we'll cover off a few different bits and pieces, hopefully bits that will be pertinent and relevant to your practice also. I'll share my screen. Um, so hopefully that's displaying okay for everyone. Okay.
Perfect.
With
Thanks,
this,
Tom.
brilliant. Unfortunately, when I'm sharing my screen, you all disappear. So this is going to be fairly informal. I'm going to keep an eye on the time, and I think we're hoping to finish most of the delivered content in about an hour. So I'll aim to get through then, but more than happy to take questions as we move through. But if there are lots and lots of queries, perhaps we'll bundle some up towards the end. So what are we going to cover tonight? So we'll go through a little bit of background of why it's important to keep robust notes essentially in the scope of delivering clinical services, and certainly the direction of travel for community pharmacy is moving away from the traditional supply functionality towards further clinical service delivery. So hopefully what we go through tonight will only become more pertinent to our roles. We'll talk a little bit about consultation models and supporting theory, and I'm sure many of you will have done the independent prescribing course or will be thinking about doing it. So we might touch on some stuff in here which is revision. So there may be bits which are familiar to you, but we'll go through why they're important, and we'll pull out a few bits and pieces as to how it may inform how we structure, how we record our notes within a clinical system or over the course of providing something such as a pharmacy first consultation. The real meat of the evening is going to come in when we talk about when we do a walkthrough of note taking. So we'll take a clinical example, we'll walk it through right through from initial presentation as they walk into our consultation room, right through to making the plan and safety netting them at the end, how we would record each step of that journey, what level of detail we want to provide within our clinical records, and some of the tips and pitfalls that come with that. So there are lots of common mistakes or things which bind us up with loads of time, and things which can also save us time as well and enhance the quality of what we're recording. And then we'll round off with some references and supporting information. So in terms of where I'm coming from delivering this evening, so in terms of my clinical role, I practice for a day a week within a general practice, and all the stuff I see now is acute. A lot of it comes out of pharmacy referrals from when patients aren't eligible for pharmacy first in the community pharmacy setting. So when they might need higher acuity of care or the initial presentation hasn't resolved with that initial PGD supply through community pharmacy, but also other on-the-day stuff. Whereas when I had a broader clinical role, it used to be centered on a lot more mental health and general long-term condition management. So hopefully I'll be able to bring some insight from that side. However, I may be a new name to some of you because I hail from deepest, darkest Devon. I'm down in Plymouth and practice over in Cornwall. So we are very lucky to have Sean here as well, who'll be able to give us a little bit of local context on what's going on with GP Connect. But I'm getting ahead of myself. So last orders at the bar, make sure you've got yourself something nice to drink and nice and cozy enough as you can be. Let's get started. So clinical note taking, why is it important? Essentially, it's important because making notes when we provide clinical services is contemporaneous evidence of your clinical practice. It demonstrates that you're adhering to the pharmacy first PGDs, and it provides a clear handover to other providers. So it's really important that we have contemporaneous evidence. What does that mean? It means that we've documented something at the same time that we've done it. And that's important both for provision of ongoing patient care. It increases the fidelity of the notes that we make, but it also, from a legal perspective, it's really important that we make notes when we see patients. We'll touch on that a little bit later. At the bottom here of this slide, I've included some guidance from the PDA back in 2019 for pharmacists, really focusing on pharmacists going into their new roles in PCNs at that point, and beginning to broaden the breadth of their prescribing. And they identified high-risk scenarios from some of their claimants. And they highlighted things such as undertaking prescribing and providing clinical advice to those who are not present, prescribing for patients without reference to their clinical records, prescribing for walk-in patients where a diagnosis might be required, and there's some other bits about alternatives there as well. But actually, these all ring true for the direction of travel that community pharmacy finds itself on. Very much the expansion of the pharmacy first service sees community pharmacists as providing walk-in services or referred services for patients with undifferentiated illness, where you do have to take a history, examine, provide a diagnosis, and provide a treatment. Although that's within the structure of a PGD at the moment, there's lots of work going on around the Vanguard sites and the expansion of prescribing into community pharmacies also. And certainly with pharmacists joining the register this year for the first time as prescribers, I am sure this will only continue, and we will see prescribing routinely happening in community pharmacies in the future. So it's interesting, I think, that even though this advice is somewhat dated, it's 7 years old now, coming up to, it's still relevant in terms of the scope of practice that community pharmacy is moving into, and probably just a flag for us to be aware that we need to do something a little bit different and just have an element of caution when we're providing these clinical services, but also in how we document them so we can support ourselves, support good transitions of care if our patients need to be escalated, but also provide a robust evidence of what we've done in our community pharmacies. So, when do we need to write notes? This is guidance taking out of CQC recommendations, looking at medical records and carrying out clinical searches. So essentially, these are the standards which are set for general practices, set for some social care settings. The thing that I really wanted to highlight here was that notes are contemporaneous and demonstrate that staff are working within their competencies. That first bullet point there. So these are essentially standards that the CQC will assess recorded notes against to ensure that providers of care within primary care, not pharmacy at the moment, but that may change in the future, are meeting the expected standards in terms of their clinical note taking. It's really important that they're made at the same time as the clinical service is delivered. So I can certainly remember, and I've spent many years in community pharmacy, over 10 years in total, before moving into general practice. There were times when things would be stored and put onto farm outcomes at the end of the day. A lot of clerical stuff would be put on in one episode. In terms of pharmacy first and providing clinical services within the pharmacy, unfortunately, it's no longer acceptable to store up our note taking to put it onto a clinical system later in the day. So think about when you're going into the consultation room to see that patient and provide that episode of care and potentially provide a PGD medicine or some advice. You need to ensure that within that single encounter, you're also making notes or have made notes by the time that you finish that encounter with the patient. And that's really important because these are the standards against which other providers of care are assessed against. The GPHC currently regulate pharmacies. However, there is an ongoing debate about the role that CQC plays in the scope of pharmacy services. And it may very well be the case that records are assessed over the course of pharmacy inspections in the future to ensure that certain standards are being met. There's some other bits in there as well, which I'm not going to touch on, but just think about how you might be doing this at the moment and how you're doing this if you're providing remote care as well. I've taken an excerpt from a legal blog talking about clinical negligence claims, because this is often where a lot of our heads go to in terms of note keeping and thinking about what our records do and provide some security for us and provide for some protection if we are in some form of clinical negligence case in the future or something may have gone wrong. And there is this myth out there that some clinicians think that the less you record, the less they can get you on. And I've certainly heard that from many primary care clinicians, pharmacists, nurses, doctors, across the board in terms of the less you record, the better. Whereas actually, this is really highlighting that everything should be recorded. Then the treating clinicians are fully aware of the patient's conditions, medications, treatments, and investigations, and are able to make an informed decision on the care plan going forward. Contemporaneous records also have an ability to narrow down any contentious issues and provide a defense. So essentially what I'm doing with this quotation here is advocating the point for making comprehensive clinical notes, not feeling that you have to write the absolute minimum possible, but thinking about a way you can do it as smartly as possible so you're not spending additional clinical time writing War and Peace in someone's notes, but you're writing pertinent, succinct notes that capture everything you're doing and don't leave any space for equivocation within that as well. I won't go into great detail about it, but certainly from my own experience as a prescriber, when I first started prescribing, I had a complaint within my first year of being a prescriber, and it was only through my clinical notes that that complaint was resolved, essentially. The patient claimed that I had changed a medication to something which I hadn't. And I had written War and Peace because I had the fear of God in me when I first started prescribing and writing clinical notes. And luckily, the entire encounter was captured within those clinical notes. So really making the case for don't try and write loosely, don't try and write vague summaries to save time or to think the less I write, the better. You want to be comprehensive, but you also want to do it in a way which is succinct and doesn't take up a lot of your time. I wanted to touch on case law before we begin to really dive into our thinking around how we structure our notes. And why am I talking about this? I want to talk about it because it is relevant to what we put in our clinical notes. And it's about the options that we offer patients, even within the structure of a PGD, but certainly as we move forward to prescribing as well in community pharmacies. So this is thinking about what the bar is in terms of the options that we offer patients and how we make decisions about the treatments we provide. And I've done this in a historic way, and I want to take you on a journey through where case law started and where we are today. So unfortunately, all of these cases are quite tragic, and there's lots more information in the reference at the bottom of the slide if you do want to read further on any of these. But the first watershed moment was in 1957 in the Bolam case, where essentially this was around a patient who was receiving electroconductive therapy. So they are receiving shock therapy for mental illness, and the doctor organizing the therapy didn't provide muscle relaxants or restraint prior to that procedure. And what came out of that legal case when the family brought this against the doctor who provided this therapy was a doctor is presumed not guilty if they act in accordance with what other doctors with appropriate expertise would do in that situation. What does that mean? This meant that if you acted in a way that other healthcare professionals would act in similar circumstances, you were fine. So the legal test for these sorts of cases of clinical negligence was a jury or a peer group was assembled within that legal case. They might ask a group of 5 other pharmacists, would you prescribe this medicine? Would you give this PGD medicine? If they said yes or no, and it concurred with your actions, great, you were fine. This modified somewhat in the Belitho case, and this was the case which centered on a 2-year-old with breathing abnormalities. The doctor didn't respond to a bleep message when the child had difficulties, as his bleep had low battery, and I think that the child unfortunately died. The mother sued and said that the child should have been intubated, and a panel of other doctors was assembled to assess whether they would or have not intubated the baby in this case. And the panel said they wouldn't have intubated if they had attended. Therefore, it didn't matter whether the doctor had attended or not. The tweak that the Belitho case brought to this was that not only did the jury of peers feeding into the case agree with the actions of the doctor, they did so in a way which really expounded that their actions were logical and defensible. So added another layer of another burden on top of merely being in agreement with a group of like-minded healthcare professionals would have acted in the same way. Looking at these two cases and how clinical negligence decisions were made previously, you can see a lot of it centers on the actions of the clinician. There's very little agency for patients in here, and patients don't factor at all in the test. It's all about, did the clinician providing the treatment act in accordance with what other clinicians would have done? The real changing point for this was in the Montgomery case in 2015, and you may well have heard about this. I think there was a PJ article. There were certainly lots in primary care literature relevant to general practice, and I think there was some in the PJ about this as well, which essentially this is where a mother with diabetes gave birth vaginally when she was not informed of the risks or given the option of having a C-section. And essentially, in that situation, in the scenario that the mother found herself in, if she had had a C-section, the child she gave birth to would have had a lot lower risk of having birth injuries. And unfortunately, the child was born, I think, with a dislocated shoulder, had birth injuries, and developed cerebral palsy as well, which potentially could have been mitigated had she have been given the option of receiving a C-section. The doctor charged with her care made the assessment themselves, said a C-section isn't necessary to themselves, and didn't provide that option to the patient. This is where the tables really turned, and in this case, the doctor was found liable of negligence by not offering the patients all the options available to them and not articulating the risks and the benefits of each of those options. This piece of case law was really important because essentially it said to all healthcare providers, when there are options available to patients, you need to tell them what the options are and the relative risks and benefits of what those options are also. We can see now how this factors into our note taking, because we need to be thinking about, have I given the patient all the options available to them, and have I told them the risks and benefits of those and documented that somewhere? This was tweaked somewhat further in a 2023 Supreme Court case because Montgomery case essentially said you have to tell patients all of the risks and benefits. The McCulloch case, I'm not going to dive into the ins and outs of the actual proceedings. Essentially, what this did was say reasonable risks and benefits of any treatment and associated treatment should be given to patients. So you don't have to read all of the side effects, all of the cases published relevant to each treatment that you might be recommending. But you need to be thinking about that in terms of when you provide PGD medicines, prescribed medicines, over-the-counter bits and pieces. You need to be providing options and the risks and benefits reasonably of each of those. And certainly if we're providing clinical services, we need to record that we've done this activity also. So that's a whistle-stop tour of what history tells us around case law and in terms of providing patients with risks and benefits of the options available to them. How are we going to record this? I wanted to reflect further that the way in which we make our notes is really important. If some of you have had the opportunity to work in other sectors beyond community pharmacy or routinely come into contact with notes that other clinicians make, you'll see that people have their own particular styles of writing notes, their own particular phrases, and you might pick some of these phrases up and include them in your own notes. From the end of 2023, patients have had access to their free written text and their GP consultation notes through the NHS app. So the vast majority of patients now can, through their NHS app, see what clinicians have written about them into their health records following an appointment, unless that clinician has specifically stated that that record should be hidden from the patient. And this is a really brilliant article from the BMJ, which is a commentary piece talking about how our words can disempower patients. And actually, it's really easy to belittle patients, to potentially patronize or blame them just by the way that we frame things. So there's some problematic terms on the left-hand side. So you may see patient denies these symptoms, whereas actually, is the patient denying them, or are they merely reporting that they don't have those symptoms? So you'll see many of these phrases used the more you come in contact with clinical notes. And it's just a note to think about, how would you write this to a patient? And there is a real move to shift towards writing our notes as if we're writing them to patients, as opposed to writing them for ourselves or for other clinicians. So, for example, specialist letters historically were always written from secondary or tertiary care specialists to a patient's GP, whereas now increasingly they're written directly to patients. And you may see increasingly clinical notes written directly to patients. This is true in other services outside of healthcare. So I also have another role in social care. And the notes I make about the children that I come into contact with through those social care services often we are advised to write them to the children themselves, as opposed to merely recording what we see in terms of their behaviours. And there is no right or wrong way of doing this in terms of how you make your notes. If you find it easier to write your clinical notes to a patient, you came in to see me today, you were complaining of a sore throat, or you presented with a sore throat, that's absolutely fine to use that language, and other healthcare professionals will be phrasing theirs in the same way, even if it's not routine practice currently. So it's just something to consider. Talking about that GP notes view functionality, I also wanted to touch on GP Connect. So certainly this is on its way. The intention is to give access to other healthcare professionals to see patients' notes, to give view functionality, to be able to update their notes by giving read and potentially write functionality in the future, and also manage appointments. So there's increasing functionality, hopefully, where other providers of care can book patients directly in to see GPs or clinicians within that GP practice. And certainly that's come online with 111, being able to book patients in directly with patients. However, although this is part of GP practice contracts now, it's in the GMS contract, the way it's implemented varies significantly locally from one locality to another, which is why I'm very lucky to be able to introduce Sian Williams at this point. Sian, if you're there, to be able to give a little bit of local context about what's happening in the area around GP Connect and what it means for you as a community pharmacist. I'm sharing my screen at the moment, Sian. Is that all right? Do you just want to give me a heads up when you want to move to the next slide?
Yeah, that's absolutely fine. And thanks, Tom, for a great introduction as to sort of how important clinical recording is. So as many of you on the call will know, my name's Sian Williams. I work for the Integrated Care Board. I have a long background in community pharmacy, but I currently work for the Integrated Care Board in Gloucester. And just a couple of slides, just to reinforce what Tom was saying. Do you want to move on, Tom, if that's okay? Perfect. So absolutely, all our practices in Gloucestershire have switched on GP Connect update record. So all the clinical records that you flow into general practice just flow. So most of them have just said, yeah, we don't want to see it through, it just goes straight in. So that's the GP Connect update record element. So it's really positive. For years and years and years, we've been asking as community pharmacists for read-write access into patient clinical records. And this is going to be sort of the best that we can achieve right this moment in time. So you will have your clinical records that you make post your pharmacy first consultations flow directly into patient notes. So again, that catapults, what you've written and what you've obtained from the patient straight into patient view, as Tom said, as well as other clinicians' views. So again, it's something that's really important that we do our level best to get sort of accurate, up-to-date, contemporaneous clinical records. So that's the update record, which obviously sort of was in the GP contract, and all of ours have switched it on. The GP Connect access record, sort of they've switched it on. You are able to view the patient notes, and I've put in the bottom of that slide what the GP Connect access record gives you over and above the summary care records or the NHR at the moment. So it really does provide you with more clinical information than you've ever had before. So I really advocate that if you haven't got GP Connect access records switched on, then sort of please take steps to do it. If you need help on how to switch it on, then either contact your clinical system provider, the LPC, or myself, and I'll be able to give you a guide, if that's all right. Now, why does this matter? Tom, do you want to go to the next slide? No, and the next one. Becky told me to sort of crack on. Here we go. So why is this important? So again, because now patients see it, because our GPs are looking at the records that we make, they're obviously scrutinizing it. And many of you will know that sort of earlier this year, sort of there was an issue identified with some of our post-event messaging. And the issue was that we recorded pregnancy status in error. And this has caused uproar between the LMCs, and GPs have historically sort of not worked as well with community pharmacies. And this article that I pulled out from something called The Pulse, which is what I call the Daily Mail for GPs, just shows sort of some of the sentiments that our GP colleagues are probably sort of really taking issue with the government, what they're sort of trying to do, and there's obviously more issues than sort of is present from just this pregnancy post-event message debacle that they are talking about here. So that just shows the importance of it. And I've just got a couple of examples from locally. Tom, do you want to take the slides down? Because I'll just talk to the sort of the issues that I picked up locally, if that's all right. Oh, that one's not mine. That's fine. But sort of obviously I've talked about the pregnancy one. There was a patient record that was flowed into a GP clinical system that the patient viewed in Gloucester somewhere. And the patient took real issue with having the status that sort of there was lifestyle advice, smoking advice given, and alcohol advice. And this patient never smoked and was teetotal. So the patient took real issue with the practice that was in his clinical record and insisted that practice removed it. I get an email and we need to sort of really look and see sort of how that happened. Now, whether that was a pharmacist or another member of staff that actually completed that record, we just need to sort of have a look at. But obviously, as responsible pharmacist, your name is above the door. Injection entries is another thing. They're not being contemporaneous in a couple of examples, and that has caused real problems when the patient can't remember whether they had flu, whether they had COVID, or whether they had an injection at all. So again, those late records and the late claims is causing us a few problems. Too little clinic information, which Tom is going to sort of expose that sort of, what we do need to see in there, sort of in a good quality record. And also we've had of late where Pharmacy First referrals were sent, there's been nothing sent back to the surgery, which again undermines what we're advocating for referrals from our general practices into our community pharmacies. So hopefully that just gives you a few examples of why it matters and some of what we've been hearing locally. Does that give you a bit of a flavour?
Brilliant. Thanks, Sean. That's fantastic. And I think Sean makes a really good point there as well around the level of scrutiny that the records that we make in community pharmacy, how they might be received in general practice. I think it is taking a step back from it and thinking about the cultural environment in which these notes are made between one organisation and another. By virtue of the notes being made from a community pharmacy, they will come under more scrutiny than a healthcare professional, perhaps even the same healthcare professional sitting within that organisation of the general practice and making the same notes. So it's just a nod to, I'm very much not saying that's the way it should be. Unfortunately, it's just the way it is at the moment. But hopefully tonight we'll be able to get some tips on how to make sure we stay squeaky clean, both for our own support and to support our patients, and hopefully not to cause any grumblings from any third parties that we may encounter. Okay, I'm going to put my slides back up again, so hopefully you can see those. So we're going to touch very briefly on theory and models. So we've gone from something which is very real world and grounded in your local area and local practice. We're going to go a bit theoretical and then bring it back to how we make consultation notes. And again, this will become apparent as to why this is relevant as we move through. So why are we talking about consultation theory and models when we're practicing pharmacists? We do this stuff every day. Well, essentially, they will inform how we structure our notes. So you have the veritable cornucopia of different models to choose from to frame your clinical notes in. And if you dive into what stuff's out there yourself, essentially these models exist on two spectra. Some notes can be really patient-centered, so you might have heard things such as ICE, ideas, concerns, and expectations, which we'll talk about a bit later, which comes out of the Hellman's Folk model. They can be really clinician-centered and talk about what's going on in your head as a clinician and the things you have to do. They might talk about your behaviors, empathy, rapport, or they might be really task orientated, like a tick sheet. There will be elements of each of these different domains we all need to consider as we move through our consultations, but they will also feed into how we structure our notes, because there are some things that we do need to do, some tasks such as checking for red flags, signposting, safety netting, and we'll go through those shortly. So I've pulled out a very small handful of models that might be relevant to your practice and relevant to the way that you make your notes. The first is Roger Neighbour, described to me once as a sandal-wearing GP. Make of that what you will. But he wrote a really good book. I think it was Understanding Patients, or I'm trying to look for it because it's in this room somewhere. I can't see it. It's not to hand. It's a really readable book, a bit dated, but essentially Roger Neighbour's consultation model is modelled on having 5 fingers on your hand and you move through each phase of the consultation. You start with connecting with the patient. It doesn't tell you anything with regards to your clinical activities. It then says you connect with the patient, you do your consultation, then you summarize, you hand over to the patient, you tell them what the plan is, and you hand the responsibility for their care over to them, you safety net, and then you housekeep. And this is something which is really interesting, and I thought it was good to raise here. Even if you take nothing else away from this model, Roger Neighbour really highlights the value of housekeeping, which is after the patient has left your room, so you've done your pharmacy first consultation, what do you need to do to tidy up that consultation? I.e., you finish up your notes, you make sure all of the equipment you've used is away and cleaned down, and also, how are you well enough to see the next patient? So giving yourself that 5 seconds breathing space. Do you need to go and make a cup of tea? Have you seen 10 patients back to back and actually you need a minute for yourself? How are you going to make sure that you are good enough to see your next patient? It's about having that breathing space between clinical encounters. And I know that community pharmacies are really fast-paced and intense environments. It's about how do you give yourself that space to make sure you're still well enough and good enough to see the next patient. There's some brilliant evidence out there which shows, looking at the rate of antimicrobial prescribing, that skyrockets right before lunchtime because people need a break. And after clinicians have had a break and they've had their lunch, they've come back, their rate of prescribing antibiotics goes down significantly. A lot of it is tied up in housekeeping. There's stuff around burnout, and much more likely to prescribe opioids and antibiotics in the long term if clinicians are burnt out. So really, by looking after yourself, you're looking after your patients as well. So just a nod to thinking about tie off each clinical encounter as you go. Make sure you've done your notes before you move on to the next one and give yourself a bit of breathing space. There's this model called Crossing the Bridge, which essentially cuts the consultation into 2 parts. It says the first part of the consultation is all about gathering information. You do your history taking, you do your exams, you summarize, and you as a clinician check you understand what's going on with the patient. So you need to make sure you've got everything you need from the patient in order to make your clinical decision and work that up with the patient. The second part of the consultation is about management. This is where you are checking that the patient understands what the plan is. It's where you talk about diagnoses, go through your differentials, you give your options, make sure the patient preferences are explored, and the patient understands what's coming next. This is useful, and we'll use it to frame our notes shortly. Many of you will be familiar with the Calgary-Cambridge model. This is the current in vogue model through which we teach the independent prescribing course in the vast majority of academic institutions. Really useful for acute presentations of care. So specifically with regard to pharmacy first, the kind of patients that you will see, this model is really helpful because it takes us from how we start the session, gather information, examine the patient, plan, and then close the session. I do have beef with how this is rolled out for all consultation types, and I won't get into the details of why I've got issues with it when it comes to things like medication review, but that's probably granted in some of the other research bits that have come out recently. But for pharmacy first and for acute presentations of care, a really useful model, and we'll take aspects of this and use it to frame how we're going to make our clinical notes. Okay, that's enough of the theoretical stuff. At the end of this presentation, I should have said at the beginning, I don't know about you, but I can't stand it when I go to a presentation and then at the end of the night I get a slide deck as a handout, and you're looking for something and there's all these pretty pictures and actually the stuff that's been discussed over the course of the evening isn't there in the handout. So at the end of the evening or first thing tomorrow, I'll send over to Becky a couple of A4 pages which summarize all of the content that we've chatted through this evening, which is hopefully a useful handout as opposed to 50 slides of nice looking pictures and not a lot of information. Let's get to the meat of the evening then. Let's do the note-taking walkthrough where we'll take a case, move through each phase of the consultation and think about how we make our clinical notes. We'll frame it in the context of something like a pharmacy first consultation or adjacent or similar. So this is how I'm going to suggest you structure your clinical notes. Start with history. And I think as pharmacists, we often get not what's the right way to say this? I think we often get misled that examination is a skill that we really don't have. We make this big thing about not having clinical examination skills, whereas actually there's a really old study, but a really good study, which thought that about 80% of our clinical information should come from this part of the consultation to inform our clinical decision making. So we want to do our history properly, want to document it properly, and we want to think about our patient input to that history as well. So I mentioned ICE very briefly earlier in the consultation. What is the patient's ideas, concerns, and their expectations of the consultation? And we can document that as well, and that will help to show how we make our shared decisions. So we're going to start with history. Then we're going to examine the patient. So you may look down their throat, you may look in their ear. I recommend, in terms of note taking, do it briefly, do it comprehensively, but don't spend a lot of time here. It's easy to get bogged down in writing what you did in your clinical examination as opposed to what you found. And we'll go through in detail how we're going to do this shortly. Then we're going to cross the bridge. So if you remember that model, the first part of the consultation is us working up from the patient, making sure that we understand what's going on. So we are doing history taking and we're clinically examining. Then we're going to cross the bridge and then think about how we develop our management plan together. Starts with a diagnosis. And again, we can sometimes get queasy about that word, diagnosis. Doesn't have to be a definite, I know what's going on, you've definitely got this. It can be an impression. It can be an idea. And we need to include our differentials here as well. That's fine. And then finally, we're going to talk about how we develop our plan, how we document the plan, and how we safety net our patients also. My recommendation from this real crude look from above of what the consultation looks like, spend the most time on your history taking and your planning. We get so bound up in not knowing or thinking we don't know enough about examination and diagnosis. I really recommend spending the majority of your time in the consultation and your note taking in the history and the plan that you make with the patient. So let's start with the patients walking through our door, or not even at that point yet. What are the details of the appointment that we have with the patient? If you're using Farm Outcomes or a similar other IT providers are available, but I'm going to frame this with Farm Outcomes because it's the one that I'm most familiar with. If you're using Farm Outcomes, a lot of this information might be captured automatically within the presets of your clinical recording form for Pharmacy First. Things like the date, the time, the location. Those are often embedded within that Farm Outcomes recording form. But you want to make a note of, are they alone or with a chaperone? Are you doing this in person in your pharmacy? Or are you calling them over the phone? Is it a longitudinal episode of care? Are they coming into you after seeing another clinician, or is it the first time? Is anyone else in that room whilst you're consulting with them? And don't forget, the chaperone is not just for the patient. If you're uncomfortable or you're unsure, you can have a chaperone as well as a clinician. And make sure you record who they're seen by. Again, that may be automatically preset within your Farm Outcomes form, or when you log into your clinical system, it might attribute every record you make to yourself, but you want to make sure that your particulars are in that system somewhere and they're linked to that episode of care. This sounds like loads, and you're probably thinking, oh my goodness, I've not even said hello to the patient yet and I'm recording all this. Simple as this. Walk-in appointment, attends alone F2F. And there you have it. F2F meaning face-to-face. That captures and contextualizes the appointment that you're having or about to have with the patient. History. our clinical history, as we mentioned earlier, 80% of our information to inform our clinical decision making is going to come from the history that we take from our patient. It's a significant part of the notes, and rapport with patients is really important. So I'm sure we've heard of that concept of the hand on the doorknob moment, where we've not done our clinical history in full detail. We think we've sorted the problem, and as we're saying goodbye to the patient, they've got their hand on the doorknob of the consultation room. I say, oh yeah, and I've also got this crushing chest pain, but I can come back tomorrow about that. You think, whoa, 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 I'm going to pull you back in and unpack this with you now. You have to restart the consultation all over again because you may have missed something in the history. So you want to really avoid having that hand on the doorknob moment. Make sure you do justice to your history because it will inform your clinical decision making and give you the full picture. I mentioned earlier about patient ideas, concerns, and expectations. And if you see clinicians recording this, sometimes people will write, it's absolutely good practice to put ICE, in block capitals within your clinical notes and record some of the patient's ideas, concerns, and expectations. But sometimes people use ICE to say, what does the patient want? It's a little bit more than that. So you might see ICE wants antibiotics. Is it that the patient came in and said, I want antibiotics? Or is it that they've had a similar presentation before, they think they know what it is, and last time these antibiotics worked for them and they want you to give them the same? Regardless of whether you do or don't want to record this, or you do or don't end up doing it, you may find that there are consultations where it's relevant to record the patient's ideas, concerns, and expectations. If you feel it's influenced your decision making and it's relevant and important, document it. But ICE only has to be a couple of words about what the patient wants, what their thoughts are, and their expectations of the consultation as well. So what is the medical interview? This is usually what we see history taking framed around. So I'll work through each of these, and against each item I've given abbreviations. So for example, presenting complaint, PC, which are broadly recognized abbreviations for each of these phases of the medical interview. This is a structure against which you can take a full clinical history from someone, and then you can record each step of that history taking against each of these headings. Again, you may find that you don't do certain elements of this, or that you do it, but you don't need to record it. However you choose to do it, I'd recommend if you do record it in this manner, use those abbreviations because they're globally recognized by other healthcare professionals in different settings. So they'll understand straight away what you're doing if this is framed within a history. And again, you don't have to write war and peace. So you're going to start with presenting complaint. What did they come in with? So presenting complaint, the only thing I want to say here is it's not a judgment. So what is the complaint the patient comes in with? It's not tonsillitis. It will be a sore throat because that's what the patient is complaining of. Tonsillitis is a judgment, it's a diagnosis. What is that symptom, that cardinal complaint the patient's coming in with? PC is usually 1 or 2 words max. Then you're going to do some history taking of the presenting complaint, and over-the-counter things might be as method, wham. Socrates is another one. I've got some bits on the next slide talking about how you might want to structure it. You want to think about their past medical history. This might be available already in your clinical record. It might be that you just check what other conditions they have against the inclusion-exclusion criteria of that PGD, or that may influence your future prescribing. Drug history, again, this might be in your clinical record. You might have all of the medicines that they're routinely prescribed, but you need to make sure you capture over-the-counter herbal and recreational drugs. And always, when we're doing these consultations, we need to check allergies and record it as well. NKDA as a real brief way to write that a patient has no known drug allergies. Social history is usually the thing that we're worst at. So things like occupation, home environment, smoking status, alcohol, weight, diet. Again, thinking back to what Sean said around what we're recording, what we're making notes of, that alcohol advice given. Are we giving advice around alcohol, or are we recording an alcohol status? So moving through a social history, we might write teetotal, never smoked. That's all we need to record for it. So we want to think about that as well. This is usually the bit we can get squeamish about, because things such as disclosures of abuse can come out here. We may need to take sexual histories relevant to what we're dealing with, if it might be genitourinary or other systems related to that. So it's the one that we often shy away from as pharmacists, but it is something which is really pertinent to the consultation. Just record it, and if you're unsure, record it in the words that the patient has provided you with. And that's absolutely fine as well. If you're not sure what word to use, or you're searching for a fancy word to use, I certainly felt like this when I started routinely recording every consultation that I made. I thought, oh my goodness, someone's going to look at my notes and think I don't know what I'm talking about because I'm not using the correct medical words. Fine to put something in quotation marks and use the patient's direct words. That's a recognised way of practice. Then your review of systems, your system-specific inquiry related to someone's symptoms. I'm not going to dive into this in great detail. We can unpack more of this in the questions if you would like to. But here are two examples of Socrates' old carts of how you might want to work up a history of a presenting complaint. These are both based on taking history for pain management. I'm going to leave them there. I'm not going to work through it. Okay, Tom, enough talking about history. What does it actually look like? Might look as simple as this. So history, PC, pain in left ear. History presenting complaint, 2 weeks pain, no radiation, some fever, difficulty sleeping in past week. Taking a pain rating, 6 out of 10, no discharge, hearing loss, change of balance, over-the-counter paracetamol, no improvement. So if you see the way this is written, that common notation in terms of numbering of weeks, days, use that in your notes as well. Structured under some of those headings, those abbreviations of presenting complaint, history presenting complaint, drug history not there, past medical history not there, presumably captured within the clinical system within these notes are recorded. Social history is listed there as well. Lives alone, welder, carer, non-smoker, teetotal. Really succinct, one word or sentence fragments to record this. And ICE, an example of that recorded here, requests antibiotics, worried about missing work and care responsibilities. That might be pertinent to your decision if you're on the fence of whether or not you give antibiotics. The ICE might help to inform why you went ahead with providing those antibiotics in the end when you were 50-50 either way. That's an example of a history. Let's move on to examination. And I appreciate we're moving through this at pace, but I am conscious of time as well. So again, you want to spend a lot of your time doing the history properly and recording it in adequate information, in adequate detail, but also succinct enough that you're not spending ages writing War and Peace. So I'm going to move quickly through what examination looks like. It starts with, as I walk through the door, the end of bedogram. When you eyeball a patient, and I think clinicians, especially community pharmacists, you have that sixth sense where you see someone in that waiting area, you think you are ill. You are not well, and I'm worried about you. Before you even say hello, record it. Record how the patient looks in your initial assessment. This may give you clues later on in the consultation. Do they look well? How are they walking through the consultation room? Are they well perfused? Are they struggling to breathe? Are they leaning against that handrail because there's 2 steps up to the consultation room, trying to use those accessory muscles to get oxygen in? There is this concept of curtain raisers and opening gambits that Roger Neighbor talked about, which is where the first couple of words the patient says to you sometimes gives you insight into their state of mind, or is, if you're like me, whenever I go to the doctor for something, I always pre-rehearse in my head when I'm sat in the waiting room the first couple of words or the first sentence or two I'm going to say, because I get all flustered when I get in there. Patients coming to see you in the pharmacy may well be the same whilst they're waiting. And that first line or two may be rehearsed, or it may give some insight to their state of mind. Equally, it might mean nothing at all. But essentially what I'm saying here is, if you see they look unwell, they look odd, the colour's off, record it. Appears unwell, clammy, able to walk to the consultation room. If you're having a patient walk to see you in your consultation room, record it, because if they need someone to support them there, or they've got a limp, that's already giving you a clue about your examination. So when you do your examination, you want to say what you're doing, but you don't want to describe it. So it's not, I had the stethoscope in the ear, we visualized all of the tympanic membrane and the auditory canal. You do not need to describe what you're doing. State what you've done and what you found. You may also choose to include what you didn't find that's pertinent to your line of inquiry. So if you're looking in someone's ear, if you've not seen discharge, if you've not seen erythema, you may want to record that as well. And you may want to link that in with your red flags. So if you're worried about, I don't know, cholesteatoma in the attic, you may put no abnormalities visualized in the attic, something like that. There is this concept of NAD, no abnormalities detected or nothing abnormal detected. That's common clinical notation to put that. If you've not seen anything that's odd, use it judiciously. Don't use it all the time, regardless of what you're doing, because you do need to record what you're actually seeing. But if you haven't detected an abnormality, that's one way you can record it. So what does this look like? Otoscopy, external ear, normal, no mastoid tenderness. Otoscopy, so we've announced the clinical examination, but we've not given any detail on how we're doing it. OE stands for on examination, so that you're telling the reader what you're doing. Looked in their right ear, tympanic membrane has been visualized, no abnormalities detected. So essentially, when you compare with the good ear before going to the bad ear, we've managed to encapsulate that in less than a sentence on that line with OE, RE, TM visualized NAD. Whereas actually to do that, that's quite a lot of effort, but really quickly notated. Whereas the left ear, we've got distorted light reflex, bulging tympanic membrane, erythema, no perforation, no visible discharge. So we've recorded there the stuff we've not seen that might be pertinent to how we work that patient up and diagnose them. Similarly, if you're doing a big test, such as a cranial nerve test, I mean, this can take as long as you want to make it. It's at least 10, 15 minutes. If you do it properly, you may just put cranial nerves, 2 to 12 tested, normal, simple as that. Equally, thinking about how we record our sepsis markers and our vital obs as well, we can parcel them up in this method. So on examination, temp, this, BP, this, respiratory rate, heart rate. So again, we're providing quite a lot of information in the words we're using, but each word counts. You don't want to write in prose for this stuff. I'm like, the temperature on examination was none of that. Shorten it to as much as possible. Make sure you retain all of the pertinent information. I just wanted to nod here to remote consultations, what kind of stuff you might want to include. Is someone speaking in full sentences? What kind of answers are they giving? Are they tearful? Tone of voice, rate of speech? All of that can be included as well. It's very clear when someone is talking really fast and wants to get their words out, that pressure of speech. If you're doing something over the phone and someone's presenting with that, record it on examination. Pressure of speech. We might put guarded answers. You can put as part of your examination how someone is talking to you as well. Okay, that's examination. Diagnosis, another thing that we can sometimes get flustered about. We want to give one line, 1 or 2 lines maximum for this point. Be clear and simple. And by writing the word diagnosis, we don't have to say, this is the categorical answer, this is what's definitely going on with the patient. We can indicate that there's inherent uncertainty, or if we're not sure, or if we're going with our best probable answer, that's fine to indicate that as well. If you're not comfortable with using the word diagnosis, use the word impression. So going with our otoscopy example, something as simple as impression, otitis media. If you're not sure, it might be impression, otalgia, otitis media, question mark. Use question marks if you're not sure. That's what you think's going on, but you're not sure. And as with anything in life, the more of them, the more it indicates. So if you're really unsure, put 3 question marks. That's common as well. Plus and minuses can be used in here as well. Impression, mastoiditis, question marks, sepsis markers. You just want a brief insight into your workup. You can also put your differentials here as well. So you think what's going on is otitis media, your potential differentials are chronic OM. It's really important that if you've got differentials you haven't ruled out, you include them, because if a patient represents somewhere else, the other clinician, the next clinician, can see what you thought, what you treated, and what you thought might else be going on if it wasn't your first presentation, your first option. But we'll come on to that a little bit later. Okay, so that's diagnosis. Let's talk about planning. Safety netting is something that we are usually really familiar with in community pharmacy. So you may see in clinical notes safety netting advice given. This really isn't acceptable in terms of adequately documenting what we've said to a patient, because this could mean anything, in a world where literally anything means anything these days. This phrase certainly can mean anything. So what does that mean? Does that mean that I said, if you're not better in 10 days, come back to me? Does it mean I've given you specific symptoms to look out for? Does it mean I've told you what setting to go for? These words essentially are telling us as clinicians nothing. It means we've had a consultation. There's no detail captured in this. So we really need to do safety netting, but we need to do it well. So a really good way to go about this, again, this comes back to Roger Neighbour's work. Ask yourself 3 questions. So let's think about that otitis media example. If you're right, what do you expect to happen? Okay, this will resolve by itself in so many days, or I'm going to prescribe this antibiotic. It should help, but it should be better within 2 weeks. Tell the patient that. How will I know if I'm wrong? If you start getting really stinking gunk coming out of your ear, something else might be going on. If there's blood coming out, or if you start losing your balance and feeling really dizzy, that tells you that your impression, your diagnosis is wrong. Tell the patient that. And what would you do next? If this happens, go and see your doctor. When this happens, come back to me. Unless it happens, if the problem goes away, you don't need to see me again. So think about giving the patient next steps, telling them what to expect if you're right, and those red flags to look out for if you're wrong. So your advice needs to be patient specific, include red flags, escalate to appropriate settings of care, and in particular be time bound. So tell them how long it should last and tell them how long they need to wait and where they should go with it. Because it's going to be very different if someone's got a pain in their middle ear and it's not gone in 2 weeks versus, they're vomiting, they've lost their balance and they can't see properly. You're going to want them to go to different places with different levels of urgency. Articulate that to the patient, make sure it's time bound. And this is really important to include in your planning around how you've safety netted, because if they go to another setting of care, if you've recorded how you've safety netted them, that clinician straight away knows why they presented to them. So it might be something like this. To call back if symptoms are worsening or not resolved in 5 days, refer to the GP if bloody discharge or change in hearing. So how are we going to write this down?
Tom, can I just ask a quick question?
Yeah, of course, go for it.
So what I have seen in some pharmacy first consultations is people putting things like safety netting advice given or advice given as per PGD. Yeah. I'm assuming that's not acceptable, even though, it's specified within a PGD. It's a very rigid framework. You need to follow it. So, putting safety netting given as per PGD, but obviously then any follow-up clinician might not have access to that PGD. So we're sort of saying that's not acceptable either. Specify actually what you've done.
Yeah, that's a really good point, Becky. And I think there's 2 points for this. So I guess I'm coming at this from a prescribing perspective. Whereas if you're operating within the framework of a PGD, there's 2 bits that you want to make sure. Number one, you've done all the stuff in that PGD, which tells you about safety netting, so the specific safety netting advice within that PGD. And does that mean that it's patient specific? So have you gone through each of those advice criteria, even if the patient doesn't have those symptoms? Because if you said safety netting advice given in PGD, does that mean that you've given all of it that's included within that, even if they don't present with certain red flag symptoms? So it's almost a challenge to yourself as a clinician. If you've given all the advice which you need to safety net against within that PGD, by all means record it. But it's a really good point as well that if someone else sees your notes, it's not particularly clear what that means. So it means a lot to you. Doesn't mean anything to the patient. It doesn't mean anything to the next clinician. So you might want to think about, by all means, include it. Safety netting advice provided as per PGD, then you may want to include 1 or 2 patient-specific things. If no better within, what did you tell the patient? No better within so many days, refer to the doctor. If these symptoms, discharge, bloody discharge, refer to escalate to A&E. So think about what's really pertinent to how that patient escalates, and I would include that as well. Does that cover that off, Becky?
Yeah, perfect. Thanks, Tom.
Okay, let's crack on, because time's marching on. So how do you want to write your plan? I'm a big fan of doing numbered plans, so be clear and stepwise. Anything you provided or stopped, make a note of. Risks and benefits, this goes right back to the case studies and the case law that we talked about in the beginning. We want to talk that we've articulated this to the patients. You want to give details of what advice you've given. You're writing this for the next healthcare professional. This plan is not for you, it's for the next healthcare professional, and you want a safety net in there as well. So an example of this might look like this. So your plan is number one, what you're prescribing or providing, amoxicillin through PGD. 2, over-the-counter stuff. 3, your advice regarding side effects. 4, refer to GP if loss of hearing, balance impairment, systemic symptoms, or no improvement worsening after 3 days. 5, written information provided. You can paste links in as well. But using this in a PGD example, number 4 is your patient-specific safety netting. You've told them here, go to your GP if you get these symptoms or if no improvement after 3 days. Something simple like that. If the patient rocks up to the GP, they can see straight away while they're there. So we're going to wrap up with some common pitfalls and top tips. I know this is a whistle-stop tour, but there's a lot to go through. So things to not do. You don't want to waffle. You don't want to waffle in life, and you don't want to waffle and give yourself more work in writing it up as well. Don't write in prose. Sentence fragments, specific, succinct, retain the information in as few words as possible, but don't cut stuff out. You don't want to leave it open-ended, end with an impression and don't say what's going to happen next. Make sure you include a plan. Make sure you include your safety netting advice. Think about, are you recording a judgment or a fact? So like that presenter complaint. Is the patient angry or are they raising their voice? So they're two different things. You want to record facts and not judgments. And if you do record your judgment, write it. I think that this is going on. That's fine as well. You don't want to duplicate effort. So, writing things on paper and then finishing the consultation and writing up your paper notes. Get used to writing directly into your clinical records. Might feel alien if you're not used to it. Get used to it. It will save you time in the long run. If you provide lots of remote consultations, buy a headset. There's good evidence to show that if you can hear yourself typing, you're doing it on speakerphone, you type slower than if you've got a headset and you can't hear yourself typing. Buy a good headset if you're doing lots of remote stuff. Don't save your write-ups for later. Don't use ambiguous or your own made-up abbreviations. This sounds like jovial, but people do this. Don't make your own up. There are ambiguous abbreviations out here, such as TX, that can mean treatment, transfer, therapy, therapist. SI, and that's one that I've used. It could mean suicidal ideation, intent, sexual intercourse. So there's a lot that can be unpacked from that. I've given a list of some ones that you potentially might want to avoid. So there are abbreviations out there which can mean many things that you might want to steer clear of. Equally, there are ones that are universally known. So those sections of the medical interview we talked about earlier, presenting complaint, history, presenting complaint, etc. ICE, NKDA, abbreviations for your examinations, your standard dosing, contextualized abbreviations. So R by itself could mean a number of different things, but R here is obvious. Use pluses to mean lots. The more of them they are, the more of them it is. So plus pain means loads of pain. Plus pain means a little bit of pain. Your minus V and plus B for negative or positive. Fast test negative, I think, is the example that pops up. Yep. So thinking about using those as well. Again, there's a link to a trust page. I think it's the NHS page on this one now, which gives them commonly used medical record abbreviations. So my top tips for making your clinical records. Make sure you do it at the time you perform your clinical encounter. So even if it's when the patient said goodbye, make sure it's contemporaneous. Don't save them to later. You make yourself more work. You'll have that cognitive load in your brain sitting in the back that you've got to write something up. You'll make poorer notes. Do it when you have your clinical encounter. Announce to the patient what you'll be doing when you come to see them. Is it all right if I make some notes while we talk today? And that sets the scene nicely and gives you permission to do it. As mentioned, buy a headset if you're doing lots of remote stuff. Don't leave the consultation room until you've finished. You want to be exacting, so you want to be comprehensive and concise. You don't want war and peace, but you don't want to miss stuff out. Be polite in your note taking. Write it as if you're talking to someone, and if it helps you to frame it in that way, by all means, write your notes to the patients you see. Be objective. Don't keep your judgments in there, and support any of your opinions with evidence if you do record your judgments. You want to make sure you include a plan. And this is a real opportunity for reflective practice as well. So I know it can be lonely working in community pharmacy. Often you're the only pharmacist, or you may be the only pharmacy technician working within those premises. Think about your GPHC validation conversations? Can you get a peer to review your clinical notes and give you feedback on your clinical notes? One of the best things that a lot of medics do is record their consultations and listen back to them. I've done it with several of my consultations, both in health and social care settings, and they've really informed, only for my own learning, they've informed how I talk to patients, how I frame things, and how I think I've spoken to someone. It's not always the way I've actually spoken to someone. So if you can get recordings of your own consultation and grin through the cringe of listening to your own voice back, it will bring dividends in terms of what you can learn from your own consultation styles and listening to it objectively. But in the absence of that, if you can get a peer to review your notes, and it might be, if you're working within a PCN, you might ask someone from the practice you're working with to look at your notes and say, what do you think about this as pharmacy first notes? Is that what you'd expect? Anything you want more or less of? Builds mutual trust by doing that process as well. You share your vulnerability, and you allow that person to provide you with feedback. You want to make sure you choose the right people in the practice to do that as well. Brief nod to reference books. So if you're thinking about you want to hone up your clinical skills, there's lots here. My top picks are Symptom Sorter. It's great for community pharmacy settings. It groups conditions by symptoms that people might present with, i.e. tummy pain, there's a chapter on it, headache, there's a chapter on that. Tells you the key red flags, things to ask, things to rule out, and consideration of investigations as well. People wax lyrical about McLeod's. I don't like it. I think it's too academic. If you're doing advanced clinical examinations, or if you're getting into examination of body systems, this book here, Essential Examination, distills down the key notes around how you interrogate, like, how you do proper otoscopy, how you review a respiratory system. If you're expanding your practice and want something to support that, recommend this one. There's loads of these on the RPS library as well as one of my favorites, the Symptom Sorter, but also Symptoms in the Pharmacy has a new edition out, and that's fantastic. And there is now an Oxford Handbook of Clinical Pharmacy, as well as the others in that series. Some further reading, if you want some bedtime reading, there is a generic medical record keeping standard. So both the top and the bottom document are linked to the same provider in terms of recommendations on how to keep clinical records. If you want the short read, the top one provides some really hot tips on how to keep good medical records. The bottom one's a long read, and there is a Geeky Medics page on clinical clerking as well, but it's a bit more focused towards hospital settings. You may take some good stuff from there, but it does frame the medical interview quite nicely. So in summary, I've rattled on at you for the past hour, and I hope it's been useful. But if you take nothing else from this evening, take this page with you. And this is one of the few slides I've kept as is in the handout. So think about chunking up your note-taking into these 4 parts: your history, examination, diagnosis, and your plan. Start with those headings and you can work from there. You want to be precise, concise, and comprehensive. You don't want to be writing War and Peace. Be polite, write your notes to the patient if that helps, and be objective. Don't include your judgments unless you're specifically saying that you're doing so. Take a systematic approach to how you do this, and think about writing your notes, not for yourself, but for the next clinician and for the patient as well. So that's all of the slides for this evening, and I hope that's been useful. But I note that I've not stopped at any point for questions because there's been so much to go through. So I wonder, are there any questions at this point? Or have you had quite enough of me and just want to get a good night's rest? More than happy to take questions if there are any. Go on, Becky.
I'll throw you a bit of a curveball if you want. I think I know what the answer to this will be. There has been a lot in the press, well, in the NHS press this week about use of AI in consultations. So the advice that we've sort of consistently given is don't use AI at the moment in any consultations. What's your view on use of AI? And I'd say if we can't do the basics right ourselves, we shouldn't be relying on AI anyway. So but what do you see it going?
It's a really, really interesting point. So AI, you're using a technology and using it to support your clinical, the provision of your clinical service. So there's the first part is there's a governance element to it as well. You need to think about, am I using a technology which is approved for use within an NHS premises? So does it have a data protect? I think it's the DPIA. There's a data protection impact assessment that the NHS publishes against certain technologies. So there will be approved products, digital products that you can use. Then you also want to think about, where is that data going? So where does the server sit? Because if the server for that AI, which is doing thinking and then putting stuff into clinical records, is outside the UK, that could be a data risk in terms of, so NHS data shouldn't leave the UK at all. And there's been many services which use external providers to this country, and they have to do a lot in terms of N3 connections and making sure there's secure end-to-end data encryption. So there's that level of assurance that you need to be comfortable with as well. But thinking about what AI can do, so it's a good point, because some practices are using stuff like Heidi, like Joy Notes, to summarize their notes. And essentially what they do is they have a dictaphone that's recording the consultation, and it will create and generate a performer of the notes for review by the clinician at the end. The trouble is, if you're new to making clinical notes, it takes away some of the learning that you will get from doing it yourself. If you're really confident with it and it's your bread and butter and you're doing these consultations every day, you're note taking, and you don't have to spend any additional time for the consultation because you've got it down to a fine T, then perhaps you might want to consider using AI within a practice setting where you've got those governance assurances to perhaps phrase how your notes go in. And then review them at the end. But that's another additional skill itself. If you're new to making clinical notes, I wouldn't recommend using it off the bat, because you'll lose some of your own learning in terms of structuring it within that way and knowing how you want your own notes to be viewed by patients as well, and then considering whether the AI tool you're using meets your own standards, because it's your own liability. The AI may produce a beautiful summary of your records, but is it recording the stuff that you've not detected that actually you would have written had you not used that AI tool? So I think it's fair to say, if you're not sure, focus on developing your own skills first and then explore it later on when you're confident with it. There's some really interesting research, and if it's something you're particularly interested in, there is a Charlotte Bleasy is a researcher in this area and has done lots around the use of AI integrated with clinical notes. And oddly enough, AI is often used to help patients access their notes. So it can be used to make notes sound a lot more empathetic, a lot more accessible to patients, but it may lose some of the clinical relevance in that translation. So there's talk about, do you have an AI service which is parallel to clinical notes, which puts things into patient language, but it's clearly flagged as that. But that's a long way of me saying, if you're not sure, stick to making your own notes for a moment. By all means, explore it. But I think in the context of what community pharmacy provides at the current moment, it might not be something which is high on the priority level. It's something you'd want to speak to the ICB about potentially as well in terms of data governance, because there's stuff out there for primary care. I don't think there's the same stuff out there for community pharmacy.
Lovely. Thank you, Tom. Did anyone have any other questions? I know I especially like the suggestion right at the end to actually sort of use this opportunity to peer review your clinical note taking. And I just sort of say, if you don't feel confident speaking to your local practice pharmacist, you can reach out to the LPC or to Sian. We're more than happy to provide someone who's better at it than I am to come and to come and sit and talk through it. And I know Sian is excellent, having been a prescriber for donkey's years. One of the first prescribers Sian was. So we've got a wealth of experience in Gloucestershire to come and help people. You just have to reach out and ask. So